Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient suddenly develops an explosive headache while doing normal activity. They describe it as the worst headache of their life, then vomit, become photophobic, and perhaps briefly collapse. In an MRCP exam, that story should immediately make you think of subarachnoid hemorrhage. Subarachnoid hemorrhage means bleeding into the subarachnoid space, the space where cerebrospinal fluid surrounds the brain. The classic cause is rupture of a berry aneurysm. When that aneurysm ruptures, arterial blood suddenly enters the cerebrospinal fluid, causing two major problems at once: acute meningeal irritation and a rapid rise in intracranial pressure. To understand subarachnoid hemorrhage, think in four boxes: why it happens, what it does to the brain, how it presents, and how we diagnose and treat it. Most spontaneous subarachnoid hemorrhage is aneurysmal. A berry aneurysm usually forms at an arterial bifurcation, where vessel wall stress is high. Over time, congenital or degenerative weakness in the arterial wall can lead to aneurysm formation. Then rupture causes arterial bleeding directly into the cerebrospinal fluid. The immediate effect is a sudden rise in intracranial pressure. Blood enters a fixed intracranial space, pressure rises quickly, and cerebral perfusion can drop. That is why patients may collapse, have a seizure, or present with reduced Glasgow Coma Scale. It is not just pain, it is acute global brain stress from raised pressure and transient reduction in cerebral blood flow. The second effect is meningeal inflammation. Blood in the cerebrospinal fluid acts like a chemical irritant. This produces meningism, so the patient develops neck stiffness, photophobia, headache, and vomiting. Do not confuse this with infective meningitis. In meningitis, the trigger is infection and inflammation of the meninges. In subarachnoid hemorrhage, the trigger is blood irritating the meninges. The delayed problem is vasospasm. Blood breakdown products in the cerebrospinal fluid irritate cerebral arteries. This leads to cerebral arterial vasospasm and impaired autoregulation. The key exam point is timing. Delayed cerebral ischemia classically occurs between days 3 and 14 after the bleed. So a patient who initially survives subarachnoid hemorrhage can later deteriorate because narrowed arteries reduce blood supply to the brain. Another important complication is hydrocephalus. Blood can obstruct arachnoid granulations or block cerebrospinal fluid pathways. The result is impaired cerebrospinal fluid absorption or flow, leading to ventricular enlargement and raised intracranial pressure. So if the patient becomes more drowsy after the initial bleed, think about rebleeding, vasospasm, seizures, hyponatremia, and hydrocephalus. Now let us connect the mechanism to the clinical features. The classic symptom is thunderclap headache. This means a sudden, severe headache reaching maximum intensity very quickly. The mechanism is abrupt aneurysmal rupture causing meningeal stretch and irritation. Patients may say it is the worst headache of their life. Neck stiffness, photophobia, and vomiting occur because blood in the cerebrospinal fluid causes chemical meningitis and because intracranial pressure is raised. Collapse, seizure, and reduced consciousness happen because the sudden pressure rise can briefly reduce cerebral perfusion. Focal neurological deficits suggest local ischemia or direct effects from the aneurysm. A very high-yield focal sign is a third nerve palsy. A posterior communicating artery aneurysm can compress the third cranial nerve. The key clue is painful ptosis, diplopia, and a dilated pupil. In an exam stem, painful third nerve palsy plus sudden headache should make you think about a posterior communicating artery aneurysm until proven otherwise. For diagnosis, the first-line investigation is an urgent, non-contrast CT head. This image shows a classic CT appearance of subarachnoid hemorrhage. The important finding is bright acute blood filling the normally dark cerebrospinal fluid spaces, especially the basal cisterns, the sylvian fissures, and the interhemispheric fissure. Blood in these subarachnoid spaces strongly suggests aneurysmal subarachnoid hemorrhage until proven otherwise. This is why CT is the first test. Acute blood appears hyperdense or bright against the darker background of cerebrospinal fluid. In an exam image, do not just look for a large intracerebral hematoma. Look carefully at the basal cisterns and fissures because subarachnoid blood tracks through the cerebrospinal fluid spaces. CT is most sensitive early, especially within the first 6 hours. MRCP trap, a negative CT does not always exclude subarachnoid hemorrhage if the clinical story is convincing. If the CT is negative but suspicion remains high, perform a lumbar puncture at least 12 hours after symptom onset, looking for xanthochromia and elevated bilirubin. Once subarachnoid hemorrhage is confirmed, the next question is, where is the aneurysm? CT angiography is used to identify the aneurysm source. If CT angiography is negative, but suspicion remains high, catheter angiography may still be needed because it gives more detailed vascular imaging. Management starts with stabilization. Use an ABCDE approach, treat pain and vomiting, reverse anticoagulation where relevant, and manage blood pressure carefully. These patients need urgent neurosurgical or neurovascular referral because the dangerous early complication is rebleeding. Definitive treatment is to secure the aneurysm early. This can be done by endovascular coiling or surgical clipping. The aim is simple: prevent another bleed. Rebleeding is often catastrophic, so securing the aneurysm is a priority once the patient is stabilized. Then we prevent and monitor for complications. Nimodipine is given to reduce the risk of delayed cerebral ischemia. Remember, nimodipine is not mainly treating the initial bleed. It is used to reduce delayed ischemic complications from vasospasm. Patients also need monitoring for hydrocephalus, vasospasm, hyponatremia, seizures, and rebleeding. If you remember one thing, remember this: thunderclap headache is subarachnoid hemorrhage until proven otherwise, and a normal early-looking patient can still deteriorate days later from vasospasm, hydrocephalus, or rebleeding. Quick recall. A patient presents with sudden worst-ever headache, vomiting, photophobia, and a normal CT head performed 9 hours after onset. What is the next investigation if suspicion remains high, and why must timing be considered? The answer is lumbar puncture at least 12 hours after symptom onset, because xanthochromia and elevated bilirubin take time to develop after bleeding into the cerebrospinal fluid. A patient with confirmed aneurysmal subarachnoid hemorrhage is improving initially but deteriorates on day 7 with new focal neurological signs. What complications should you suspect, and what drug is used to reduce this risk? The answer is delayed cerebral ischemia due to cerebral vasospasm, and nimodipine is used to reduce that risk. Do subscribe to the channel for further videos.